years old, and I was talking to a nurse on med-surg before I went to the interview. And she told me she would have aborted him because he didn't have fingers. I was like, because he's missing 4 fingers, man, she would have aborted him. It's like, I don't know, it startled me. That's all, it just startled me. And that's it for chapter 2. Look at us go. Reproductive anatomy and physiology. Chapter 3. Oh, we did. Doesn't look like we did chapter 3. Why didn't we do chapter 3? Looks like a lot of review. You guys know about taking babies, right? I'm not going to ask you all the different, when does your egg get released? What is your lutein hormone doing at that time? I'm not going to ask you that. Yeah, chapter 4. I have written on the side of page 61, teaching patients. Yes, genetics. We have to understand genetics and how they work because we're a big part of teaching our patients. They have decisions to make as far as reproduction, and we can help them by giving them the information. So, chapter 4, page 61 would be a good thing to review. And you remember the difference between meiosis and mitosis. We make babies in our ovaries. My ovaries, not mitoses. Meiosis is reproductive. Understanding dominant and recessive. Studied that probably in high school, yes. So refresh your memory on that. Understand what is a genogram. Being the dog person I am, it's kind of the same thing as a pedigree, right? So a genogram on page 64. I have this highlighted, I think, just because I think it's funny. So male is XY. Few genes are found on the Y chromosome. I think that's funny. So if you have an XY and there is a problem on the X, you probably are going to have that problem because you don't have another X to counterbalance it. If you have 2 X's, very likely the other X is going to be healthy and it's going to override the bad gene on the bad X. Let's see. So just kind of review that stuff, I guess is what I'm saying. I am not going to make you map out a genogram. I'm not going to make you do this box 4.2. Well, here we go. X-linked recessive characteristics. Although recessive, only 1 copy of the gene is needed to cause the disorder in males. You do not have a compensating X without the trait, which is what we just talked about. X-linked traits. That is why only female cats are calicos, because they have X turning itself on and off. Down syndrome, extra chromosome. I have a big note, page 67, critical to remember. Okay, whenever you see critical to remember, study that. Okay, it's usually in purple, says critical to remember, study that. And here on page 67, under the critical to remember chromosome abnormalities, I have written understand the difference. page 69, stars around the multifactorial disorders. What I have highlighted there is, let's see, a multifactorial defect, may cause a secondary defect. Multifactorial disorders are some of the most common birth defects encountered. For example, heart defects, neural tube defects such as anencephaly, spina bifida, encephalocele cleft, lip and cleft palate, pyloric stenosis. There is a critical to remember on that page. We've talked a lot about folic acid. Teratogens, understand those teratogens. Oh, here's an arrow at the bottom of page 70. Teratogens typically cause more than one defect, which distinguishes teratogenic defects from multifactorial disorders. Got a highlighted box around box 4.3 about selected environmental substances known or thought to harm the fetus. So again, teratogens. Rubella, we talked about that, right? We don't give pregnant women rubella. So we give it to them postpartum. And then we warn them not to get pregnant. There's a little snippet on 71 about hyperthermia. More about folic acid. Oligohydramnios, abnormally small volume of amniotic fluid. I'm on page 72. Fibrous amniotic bands. That's what they think happened to my son's fingers. So the amnion has bands in it, and if one of them snaps, well, what happens is it just, it's like a rubber band that breaks and it wraps around whatever body part is right there. He's very, very lucky. A lot of them, it'll wrap around the head, for example, or the body. So, page 72, fibrous amniotic bands. Page 73, I've got a highlight around patient teaching. Which really is a lot of review of what is in the rest of the chapter. Page 74, how we might be part of the genetic counseling team. Teaching about lifestyle and those teratogens. '76. Stillborn infants sometimes have birth defects that contributed to their intrauterine death. Hold on, make sure that's not my bed. So, in addition to having lost a baby, parents have to also deal with the fact that they had a deformed baby, which, if you've not had one, maybe doesn't make a whole lot of sense to you, but there's a whole lot of hopes and dreams when you find out you're pregnant. And then you find out that the baby has some deformities, and then you blame yourself. What's wrong with me? That, Anyway, keep that in mind. High anxiety, they can't learn. Support groups. Okay, I'm in chapter 5. Did we go over chapter 5? Oh yeah, we had that video, right? The goofy, weird video where the sperm is swimming to the, am I making that up?
I don't remember that. It says 2, 4, 6, 7, 8, 17, 18, 22.
Okay, so I'm gonna skip 5. Okay, 5 is a lot about fetal development. A lot. So we're not doing that just yet. How we doing? Okay. Chapter 6. 12 weeks of gestation, the fundus can be palpated above the symphysis pubis. That's a very important piece of detail to remember. At 12 weeks of gestation, we should be able to palpate it above the symphysis pubis. At 16 weeks, it should reach halfway, midway, between the symphysis pubis and the umbilicus. When does it reach the umbilicus? 20 weeks. It reaches the xiphoid process at 36 weeks. And that's as high as it's going to go. 36.
It reaches what?
The xiphoid process. By 40 weeks, the fetal head descends into the pelvic cavity and the uterus sinks to a lower level. We call that lightening. Or in lay terms, the baby dropped.
Is that why it goes from the xiphoid process back down? Sounds like 36 to 40.
Yeah, baby's dropping, yep. So the growth of the uterus after that 36 weeks, that's when they're going this way. Just huge. Poor things. Okay, so lightning, no lightning. Braxton Hicks contractions, I'm on page 101. This is often what leads people to have what we call false labor. They feel like they're in labor. The first pregnancy, they don't know what those Braxton Hicks are, so they think they're in labor because, oh, I'm having contractions. Grand multips, while they've been there and done that, their Braxton Hicks are frequent and hard, intense. So it's just kind of think of it as the uterus practicing going into labor. Okay, it's having these little contractions, and they can be quite uncomfortable. So it's false labor when there's no cervical change. You are not in labor if there's no cervical change. That kind of defines when we're in labor. The cervix is changing. Now remember, some women can walk around at 2 centimeters dilation for months. It's the change that we're, oh, now we're at 3 centimeters. Now we're probably in labor. Still on page 101. Oh, don't forget Chadwick's, Goodell's, Hagar's. Persistent yeast infections are common during pregnancy. You can get, now on page 102, you can get stretch marks on your breasts. Just helpful to know that with these teens, right? Now they're getting stretch marks. They're mortified. So there is a lot in this chapter about the changes to the woman during pregnancy. The blood volume, the plasma volume, the heart size and position. So those would be things I would definitely want you to study. Blood pressure changes are minimal. Effects of position. Supine hypotension, that uterus puts a lot of pressure on those big veins and arteries. Small frequent meals, chewing gum or oral lozenges. Yeah, there's just a lot of information here you want to go through. Remember the white blood cell count can be elevated during and right after. 25,000. I do know there is a question for sure on the exam about that linea nigra. You guys remember what that is on page 107? So that dark line that runs down the middle of the belly. There's questions about stretch marks. on the belly and breast. Lots of, oh my God, I'm losing all my hair after delivery. Well, it's not that you're losing all your hair, it's that you had more hair while you were pregnant. You know, a lot of hair growth during pregnancy, which was a nightmare for women in my family because we have too much hair to begin with. So on page 109, there's a table 6.1. I'm only bringing that to your attention because I'm not going to ask you that detailed information about where is the prolactin coming from and what is it doing. Page 108 at the bottom starts talking about the pancreas and what that can do for people who are diabetic before pregnancy or just have diabetes. It'd be very, very difficult for them during pregnancy. And some people develop gestational diabetes. So they're diabetic because they're pregnant. Those true gestational diabetics, once the baby's born, diabetes is typically resolved. There's the exception, of course. Baby's out, placenta's out, diabetes is resolved. If it's not, then we question, okay, was it really gestational? Or did we just catch the diabetes while she was pregnant? And she really was diabetic. Estrogen, I will probably ask you a question about estrogen. Because it's doing a whole lot. Don't get new prescriptions for eyeglasses while you're pregnant. Okay. You still doing okay? Then we get into confirmation of pregnancy, page 111. You do want to know what are presumptive indications, what are probable indications, and then what are, what's the word, true indications? Positive indications. So that stands from page 111 to 114, which sounds like it's a lot, but I don't think you'll think it is when you're reading it. So if I come and I say, oh, I had a positive pregnancy test, that doesn't mean I have positive confirmation that I'm pregnant. Weird thing to wrap your mind around. Page 115, we start talking about trimesters. I'm not going to ask you what the baby is happening to the baby during the trimester, so you don't need to focus on that this test. Okay, I'm not going to ask you when does the heart develop. But I might ask things like during the first trimester, what kind of teaching does mom need? What is going on in mom's body? I've got some marks here. First trimester, nausea, fatigue. The fetus seems vague and unreal. That first trimester, yeah, you know you're pregnant, but it's just a random concept. Often don't gain weight. Emotional lability. Means you're gonna be moody as balls, okay? First trimester, lots of mood swings. Second trimester, now the fetus is real. First 3 months, all was well. Next 3 months, she began to swell. So the second trimester, we're showing the baby's becoming real. We're going to start feeling movement, what we call quickening. it to be a little bit narcissistic, that's okay. Pregnant women can be narcissistic. Lots of body image changes. Sex is always a big question in pregnancy. Yes, they can have sex during pregnancy. Are told a lot, cannot have sex during pregnancy, it will put you into labor. There's not actually any research that shows that you're going to go into preterm labor because of sex. Now, you're wanting to go into labor there at the end. Maybe labor is starting but not progressing. Maybe a little sexual activity can help. Okay? But there's nothing that shows that it's going to cause a preterm loss. There are some indications that we're going to tell you not to have intercourse. And that's at the bottom of the first column on page 117. For example, if you have an incompetent cervix, so a cervix that doesn't want to stay nice and tight and closed, probably don't want intercourse going on. If there's vaginal bleeding, then we're not going to put our fingers in there. We're certainly not going to have anything else put in there. If her membrane's ruptured, honest to God, I was working one night, her water broke, she's in the hospital, labor's not progressing very fast, and they're having sex in the hospital room. And her membrane, and we're all just like, okay, get the IV stuff out, get ready for this baby because it's going to be sick. I mean, there's nothing there to protect that baby. Anyway, I digress. Preterm labor, problems with preterm labors, don't have intercourse. Third trimester, increasing dependence. I'm still on page 117. Got a lot going on there. Preparation for birth. They start getting really nervous about what labor is going to be like. Really, really nervous. The more they are relaxed in labor, the better labor is going to go. So these, especially these primips, that we don't really tell women a lot about how labor is going to really go for them. All we do is we say, oh my God, it's so awful. It doesn't have to be awful. But the more we tell somebody how awful labor is, the more it's going to be awful for them because their body is getting tense. So part of our teaching can be to help them bring that anxiety level down so that it's not so bad for them.
Birthing classes help.
Birthing classes help. A lot of what's going on when we have pain and anxiety is we are holding our breath and stuff, and the uterus isn't getting oxygenation during that period. And so the more we tense up, the less oxygen the uterus gets, the more pain there is. So it's a cycle. Nesting, have you heard the term nesting? Okay, so if you are going to visit your sister, she's 39 weeks pregnant, and you find her on the bathroom floor scrubbing the grout, might be going into labor very soon. Steps in maternal role taking. I do think there's a question in there about mimicry. I do think there is. Role playing and mimicry. Page 119, the maternal tasks of pregnancy. I got the top of the second column, 4 things circled, 1, 2, 3, 4. Page 120, attachment begins in early pregnancy. I do want to be clear that not all women have this magical, oh, here's my baby, I adore my baby, and immediately fall in love. Not every woman does that. And maybe they do it with 4 out of 5 of their kids, you know. There are some times when you just don't bond with that baby right away. It's okay. And they need to know that that's okay. All right? Paternal adaptation, I don't have a lot in there, except to remind you that they also need education. So when they are all in the hospital, the mom, the baby, and the support person, they're all three kind of your patients when it comes to teaching. Sometimes expectant fathers do experience physical symptoms similar to the pregnancy. My husband did not, but you know. Now I really don't ask much about the dads and the kids. I really don't. Siblings. Page 123, psychosocial adaptations. Well, you know, there we're talking about age. And we talked a lot about the teenagers and their concerns for body image and so forth. Over 35 years of age have their own concerns. That is advanced maternal age. So they call that AMA. I was AMA with my last child. Multiparity. Do not assume because she's had 5 other kids that she doesn't need any support or teaching. Every pregnancy and every delivery is different. And honestly, there is a little bit of, what do you call that when you forget things? Amnesia. There is a little bit of amnesia involved after a baby is born. So 2 years down the road, she's having another baby. She doesn't necessarily remember everything that happened the first time, okay? So don't just ignore their needs. All right. 7, chapter 7. Is that in our list of chapters? My computer shut down, okay. I need to take a minute and hydrate.
What was the abbreviation you said for advanced
AMA.
AMA?
Yep. Advanced maternal age.
I'm praising her for her use of Quizlet.
Oh.
Are you putting it together as we're talking? Is that what's going on?
I've been putting it
Know
together
this,
for
I
like-
know that, I know this.
Whatever it takes. Don't forget ions on Monday. And that ATI testing will be available. You can take it home, but I do think it's proctored through a remote proctor.
What?
So I'm glad I mentioned it. The ATI, you know, we're having those, you take a test and then you remediate, and then you take a test and then you remediate. So those tests you can take at home. But I think they're proctored through a remote proctor. Does that make sense?
You're talking about ions.
About what? I just mentioned don't forget ions.
Oh, I was like, how are they in there?
No.
I was like,
No,
we're
no, no.
doing little test things at ions?
I'm sorry.
When are those? When are those and when do we have to like do them?
When do you have to do it? Is that yes? Week 9, the first one is due. It's open all week.
Okay, so do by class? Or, okay,
Just during week 9.
okay.
It should talk you through it then what to do, and it really should be.
I want the bigger one.
Real?
All right, are we ready? I'll let you guys eat.